Oh, that little girl's so precious. Thank you all so much. We're going to start a Q&A section now. And I have questions. Many of you took... I feel like I'm being really breathy into the microphone all of a sudden. Many of you submitted questions that you wanted answered, so that's what we're doing right now is we're just anticipating, making sure that we get all of them answered. And we're going to start, Corinne first. We're going to kind of back up a little bit on fertility. What's actually the definition of infertility?
Okay, so technically the definition of infertility is any couple that has been having unprotected intercourse for 12 months or more without a pregnancy. That definition is shifted a little bit for women who are over 35 with the knowledge that the prevalence of infertility increases. So for 35-year-old women and older, 6 months or more of unprotected intercourse. If you don't have a pregnancy by that point, you should seek at least some testing, evaluation to see what's going on, and possibly consider starting some fertility treatments.
So for young women who are not sexually active or do not have a partner, it's a simple blood test and a vaginal ultrasound, and they can have some kind of sense of their level of fertility.
Yeah, those tests mostly are basically to evaluate the egg supply, which is probably the most important predictor of fertility, although it's not the entire story, because there's also the issues of the plumbing, the fallopian tubes and the uterus. So for a full evaluation, you would have to have additional tests, but those other parts are not usually affected by cancer treatments or cancer itself.
Now, most of us in this room, at least I think all of us who have gone through cancer treatment, are also wondering, can I actually go through fertility preservation if I have some level of ovarian reserve? I have some eggs there. Can I go through fertility preservation now after the fact?
Yes, you definitely can, and I mean part of the our understanding of cancer treatment's impact on fertility is that potentially just the reproductive window is shortened, but that there is still a window of reproductive opportunity after treatment before menopause, and so during that window of time you can definitely go through fertility preservation treatments to freeze some eggs or embryos before you reach that time of menopause when there are not eggs left. Ideally, you would want to do it before treatment, but then can also consider it after treatment.
Now, is there a way, and Dr. Weissman, I'd like you to speak to this as well, is there a way to use hormonal stimulation through fertility preservation that protects the health of the patient if they have hormone-sensitive cancers?
Well, I think there are 2 points here, and I think the standard of care is to receive hormonal stimulation before beginning cytotoxic therapy. So that's the first point. And the data that exists, several studies from Cornell and others, suggest that the stimulation and the potential delay of treatment does not impact on survival in breast cancer. So the windows that Dr. Chung was talking about, 2 to 6 weeks, I think that those windows do not create the concern that the prognosis is impacted. Now, the second question is much more complicated, and that is, what about during the treatment in which someone, for example, after they've recovered from chemotherapy, they would be put on tamoxifen, or let's say they didn't need chemotherapy and they were on tamoxifen alone. And that's a more complex issue, because right now this is an area of some investigation about women actually being stimulated on a period of time, during a period of time when they're on anti-cancer therapy. And I think there's reasons to be encouraged about that there are short windows where the risks seem to be low, or using drugs even like tamoxifen itself as a stimulatory agent, or so using it with other hormones. So I think it's a 2-part question. The first part I think is pretty clear, not a risk. The second part is investigational, but also reason to be hopeful.
Is there any risk genetically if you're on tamoxifen and you do a round of stimulation that uses tamoxifen, because there are now stimulation protocols, because tamoxifen, letrozole act like estrogen in the body? Is there a risk do we know if there's a risk to egg quality by using a medication like that actually isn't estrogen? Do we have an answer for that?
So I think that that's something that we don't know the answer to yet, but tamoxifen actually was a fertility medicine before it was a cancer medicine. So there's actually quite a bit of experience using tamoxifen in the fertility world, more for ovulation induction than for IVF. But as far as we can tell, there does not appear to be any effect on the babies born after tamoxifen. Letrozole also has been used in that setting, and so far it appears to be safe. It doesn't appear to have an effect on the babies, but I think we need to research that further to know for sure.
Okay, and we also mentioned the word ICSI a couple of times, and that's probably something that everybody needs to find. What is ICSI?
So ICSI stands for intracytoplasmic sperm injection, where a single sperm is selected out of the millions that Dr. Rothman talked about, and basically injected into the egg, and is very successful in achieving fertilization. So really, you only need a small number of sperm to actually achieve a pregnancy if we use ICSI.
Dr. Rothman, what is the average number of sperm that your donors need to have in one of their donations to actually be frozen and banked?
Well, we'd like to have a collection of 200 to 400 million sperm. And with men, the longer he abstains, the more sperm he'll ejaculate, because sperm are produced whether he ejaculates or not. But we recommend that they don't abstain more than 7 days, because sperm reach a period of maturity, and then they don't become more mature or most mature, they become less mature. So usually 200 to 400 million sperm per ejaculation after a young man abstains, 2 to 3 days.
Now, I just met a survivor 2 weeks ago who, when he froze his sperm, he only had 4,000 sperm. What are the chances that that will produce a child?
Well, actually, if there are 4,000 good sperm, they could produce 4,000 children with ICSI. ICSI only takes 1 sperm. It's interesting because when we first started storing sperm for men with, let me stand up because I'm, when we started storing sperm for men with cancer, we were storing counts that were really unacceptable as far as intrauterine insemination or even IVF. But with the advent of ICSI, we're storing any sperm. And is it Tim? Jeremiah, I'm sorry. Jeremiah, even if those sperm are not motile, they still might be viable. And there are viability studies that you could do to determine, and if they're viable, the sperm don't even have to move. They will be injected directly into the egg. And if you're going to do in vitro fertilization, ICSI, I'm not sure, is just a little bit more expensive, but it is quite successful. And I think we're reaching a point, because it's so important for an IVF lab to be competitive, that most cycles are going to ICSI, and I'm not even sure how many are, maybe share it, how many are normal IVF programs or using ICSI.
In the journey, we learned that we would have had fertility problems due to my husband anyways. He had low mobility and morphology, the shape of the sperm. And so she's an ICSI baby as well. So he had very poor results. In fact, his siblings have not been able to achieve a pregnancy, so.
She's the most scientific person in the room, that little one. Dr. Weissman, we learned about chemotherapy, different types of chemotherapy used in breast cancer. In chemo, is it the same impact on men and women, or does it really depend on the exact chemotherapy? I mean, we've heard that they fall into low, medium, and high risk, but is there biologically something different between men and women, where women are more at risk for infertility than men?
Well, each agent creates a level of risks for women, and I think that has to do with the way the drugs work on the cycle on ovarian function. So I really can't comment on men in terms of whether they're the same. My guess is they are quite similar, but most of the chemotherapy agents for women in the adjuvant setting, which is the women who don't have metastatic disease but still need chemotherapy, are based on what's called alkylating agents, and those are the ones that are probably the most inducing ovarian failure. So if we had a protocol that allowed us to stay away from those drugs, used, say, adriamycin or an anthracycline alone, that drug is less likely to cause ovarian failure. But unfortunately, all our combinations are, all our drug usage are combination based, and virtually every one of them has an alkylating agent. I think this kind of group ought to stimulate research in potentially using either single agent therapies or in low risk settings where the benefits of chemotherapy are more marginal. Maybe we have to revisit the areas of adjuvant chemotherapy because of the issues of fertility.
So far we know for women, we need a blood test and we need an ultrasound, and we can either go to a fertility specialist or our OBGYN, correct? And for men, you need to provide a sperm sample through ejaculation. Can that be done, Dr. Rothman, at home and mailed in, or at home and then brought in, or does it have to be done in your masturbatorium?
It's better to have a fresh sample. So I would say within 2 hours of an ejaculation, but it doesn't have to be brought into the sperm bank. I mean, if there are people living in more distant locations, they just have to bring it into any lab, and not to be frozen, but just to be assured that there's sperm present. And then you'd have to go to a cryopreservation center, because we have to treat sperm with a cryoprotectant agent, just like they do with eggs when they freeze it. And once they're stored, they could last forever. We give them potential immortality if you put sperm in a sperm bank.
If someone has been treated with a chemotherapy agent, they do have some level of fertility, both men and women. Will that fertility continue to decline? So they should go ahead, and even though they've been through cancer treatment, should a man still go ahead and bank sperm, or is it something that damages you right when it happens and then it stays kind of level?
Sperm develop over a period of 3 months, so there are many sperm in the ejaculate that are mature. And even if the man has chemotherapy, the sperm that he's ejaculating for about a month might be fine. They're mature sperm, they're not dividing, so therefore they're less affected. Also, alkylating agents are as damaging to sperm as they are for eggs. We usually recommend that a man wait 6 months to a year after chemotherapy, because there could be a residual effect on sperm. Some people would say longer, but I'd say at least six months to a year would be good to wait.
And how long should a woman wait, particularly if she's also on some kind of long-term therapy like tamoxifen? How long should she wait to get pregnant or try?
So after chemotherapy, if you're not on tamoxifen, it's thought that you should wait about 6 months before getting tested, because again, the ovaries kind of shut down during chemotherapy, and it may take some time before everything is kind of working again in a way that you can test accurately. If you're on tamoxifen, tamoxifen is a hormonal agent that can potentially impact some of the results that we would get from hormone testing and maybe even the ultrasound. So generally, while you're on tamoxifen is not really the time to have your FSH level or antral follicle tested. Wait until you're done with the tamoxifen.
Dr. Weissman, is there a risk for any cancer patient, regardless of breast cancer diagnosis or any other leukemia, lymphomas, skin cancer even, is there a risk to their health if they get pregnant and carry their own baby?
Well, the data, although not comprehensive, does not suggest that pregnancy and breast cancer increases recurrence risk. In fact, there is some data that says after 2 years it's even more favorable to become pregnant. So I think that that's a myth and probably worthy of describing as a non-issue. Now, the one thing, though, and I will say this to a patient, is the major risk of recurrence is early after the diagnosis of breast cancer. So let's say a patient has 15 positive lymph nodes and gets chemotherapy. They have frankly, a recurrence risk independent of the pregnancy that's in that first 3 to 5 years. And I do think there is some responsibility. This is a major emotional journey to discuss with the woman. If you get pregnant and then you get a recurrence, how are you going to feel about having a child and you're dealing with metastatic disease. And that's not a conversation that is easy to have, and I think that needs to be had in patients, particularly the highest risk group, where the issue is not the pregnancy, the issue is the recurrence.
Thank you. Do women successfully who have a recurrence while pregnant, are they able to go through chemotherapy while pregnant and deliver a healthy child? Anyone?
Just repeat that.
Women who are facing a recurrence while pregnant, are they able to go through chemotherapy again and deliver a healthy child?
Well, recurrence during pregnancy, so let's talk about pregnancy and breast cancer briefly. Organogenesis is the first, basically the first trimester, and that's when organs are developing embryologically, and that virtually all chemotherapy is not considered safe during that period of time. And that's about 12 weeks, something like that. After that, second trimester, third trimester, we feel pretty comfortable with most chemotherapy not impacting on the health of the child. So there are other complex issues Dr. Chung can address, but we do give chemotherapy routinely for breast cancer in second and third trimester without concern. Now the other issue of recurrence, that's a very complex discussion. That means delaying treatment in a patient with metastatic disease, etc. So that's a very complex issue.
As they all tend to be, don't they? This is for the entire medical panel. What is the first step or phone call that one should make when they do want to start a family? Is it their oncologist? Is it their primary care physician? Is it a fertility specialist, their OBGYN?
It's only recently, Alice, and basically because of people like yourself, that the knowledge is even getting out there. For about 25 years, we've attempted in vain to inform oncologists, oncology nurses to consider fertility, and very rarely did they. They basically thought that your life is at risk and therefore we're going to try and save your life, and the rest of it was not very important. Now I could say there's an incredible interest internationally. As you know, you're speaking in December about preserving fertility, realizing quality of life is very important, not just in quotes life itself, but the ability to achieve what one wanted to during their life, and having babies is a very high priority.
Thank you. Lisa, you've bravely chosen a sperm donor, then a surrogate, and now you're embarking on choosing an egg donor. What can you share with us about your decision-making process?
Which part?
For all of it. How do you actually start the process of whittling down hundreds and possibly even thousands in certain situations, potential donors or surrogates?
It can certainly be very overwhelming, to pick who is going to be either the sperm donor or the egg donor. But it's a lot like online dating, which I had a lot of experience with. But I mean, in truth, it really is just about being really clear about what are your non-negotiables and what are the things you're willing to give on. And so you just make a list of criteria, and you just filter your results. I mean, I'm a management consultant, and I approach the process like a management consultant with a spreadsheet and criteria, and and I ultimately, when I was choosing a sperm donor, kind of found my way to a sperm donor that I felt really great about. And I am just about to embark on the process of selecting an egg donor, and will take a very similar approach. Although I will say, with an egg donor, a lot of people don't know this, but you can meet and interview your egg donor. So whereas a sperm donor, it's frozen in a bank, for egg donation, it's not an egg bank. You're actually picking a woman who will go through the process to produce eggs for you. So it's a real person that you have to trust will go through this process the way they should. And but you do have the opportunity in many cases to actually get a really close look at this person. So it's a very interesting process, but there's absolutely a way to do it. Do you have a question? Yeah. Yeah.
Would you ever consider somebody that you know?
Oh, good question. I mean, it's complicated. right? So and do you mean for egg donor or sperm donor? Egg donor.
Can you do that for, I guess you could do it for sperm donor.
Absolutely.
Okay, but for
Absolutely.
egg donor, since you're meeting them anyway.
Right. Right. I think that certainly you can consider someone that you know, but you would have to really take into account what that means and what kind of relationship there might be. What kind of relationship does that donor want? What kind of relationship do you want? What do you tell your child? It's just, it's more complicated, and I just would say to people to just think about all of those different aspects before they make a decision. I don't think there's one right answer. It's just making sure that you really think it through. But you can do that, certainly.
Lisa?
Yes.
I just spoke with Andrea, and apparently, I'm glad Pamela's here now. The donor that you chose we found out after a while, he's an SMA carrier.
Right, and I'm not, so it's okay.
Okay, so if Pamela would be okay, that donor is available at no charge.
Oh, really?
He's probably restricted. We'd have to make sure we still have him.
That's amazing. It's like hitting the lottery, though. I mean, thank you. That's amazing.
That's very sweet.
As far as I know, and Pamela could confirm it, there's really no risk to the offspring.
As long as the egg donor doesn't test positive for it. And there's a 10% chance. Okay.
Okay, so actually, Pamela Calum, can you come up for just a second? Okay, well, I can come to you if you'd like, because this does bring up a really good question in some of the Q&A, which is talking about genetics. And there is something called PGD, which is pre-implantation genetic diagnosis. And we do have our genetic counselor here. And I don't think anybody in the room besides maybe 4 people know what SMA really means. So what is it that you're testing when it comes to genetics of, what would you test for both sperm donor, egg donor, and what should you be looking for?
SMA?
Well, let's start with SMA, just define what that is so nobody's like, what the heck are they talking about?
Okay, SMA it's a genetic condition. It's called spinal muscular atrophy, and it's a new genetic test that's now available to the general population just in the last couple of years. So we started testing our donors for it a couple of years ago. And if we had known about the donor being a positive carrier for a genetic mutation for this disorder, we wouldn't have taken him into our program, but we tested him after he was already in our program when the testing had become available. For this particular genetic condition, both parents have to have a genetic mutation for it, for their children to be at risk of actually being affected with the disorder. If Lisa also carried the mutation, she could actually test her embryos by what Alice was calling PGD. It's a process of fertilizing the egg and actually having an embryo, removing one cell from that embryo and doing the genetic testing on the embryo. So you can identify that this embryo will be a child with SMA, this other embryo will not. So you can determine the risk to your future children if you know that there's a genetic risk in advance, which is one of the concerns for even if you are choosing an egg donor or using a sperm donor and your own eggs. You also need to know about your own medical history because you've been through cancer, you've gone through fertility preservation, but you still have the same other genetic risks as anybody else who's planning a pregnancy that you might want to think about and consider through a genetic consultation when you are planning that pregnancy.
Pamela, are they routinely checking egg donors for SMA now?
The genetic testing of egg donors is different. In the United States, most sperm banks take the responsibility for doing the genetic testing on the sperm donors that we provide. For egg donors, it's very different. Because there is the individual selection of an egg donor, it would typically be Lisa's own physician who said, oh, you should do this genetic testing on your egg donor. So every egg donor in the United States has different genetic testing. We actually just did a study on that, and it's highly variable. Sometimes it's the egg donor facility who decides. In most cases, it's the actual recipient's physician who decides what testing they think is appropriate. So it's very variable, and I would say most egg donors do not have SMA testing. Most couples who conceive naturally don't have SMA testing until they're already pregnant, if they have the testing at all.
And we actually have some resources for egg donors here that we'll get them to weigh into that discussion in just a minute. But when it comes to PGD and the fact that you can actually do genetic testing on your embryos, what else can PGD test for? And what is the average cost in the country for PGD?
I don't know the average cost currently. There are different types of PGD. PGD can test for one individual mutation. So if a woman knows that she has breast cancer due to a BRCA mutation, you can actually test which embryos inherit that mutation if you don't want to pass it on to your child. But that's one, it's like a single spelling mistake in the DNA of the embryo. You can also look at the chromosomes, the large structures carrying your DNA, in that single cell from the embryo as well. And a lot of laboratories that do PGD can now do both tests for you, because the chromosomes are very pertinent to study based on a woman's age. They're very important. That's the same thing that amniocentesis is testing for later on. So there are a lot of different genetic tests that can be done by PGD.
One more question for you. Does PGD, is there a risk to the embryo by taking that one cell out?
There's always a risk to the embryo, but the technology's been around about 20 years now. There's a lot of children who've been born from PGD, but there is a chance that you will damage the entire embryo by removing a cell from it, and that's where you want to carefully select an IVF practice and know your reproductive endocrinologist's experience, and I'm sure the physicians can tell you more.